Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Kirthana Pakanati.
All right. Hi, everyone. I'm Kirthana Pakanati. I'm a cardiology fellow and the host of the Heart of Prevention, ASPC's official podcast. Dr. Shapiro, Dr. Kara, Dr. Gulati, welcome to the Heart of Prevention.
Great to be here.
Today, we'll be attempting to answer a burning question for many patients and healthcare professionals alike. What even is preventive cardiology, and why should we care about it? But before we dive right in, let me tell you a bit more about our esteemed guests for today's episode. Dr. Michael Shapiro is the inaugural Fred M. Parrish Professor of Cardiology and Molecular Medicine at Wake Forest University, as well as faculty in the section of Cardiovascular Medicine. He is the director of the Center of Prevention of Cardiovascular Medicine at Wake Forest University School of Medicine and is the co-director of the NIH T32 Fellowship Program in Cardiovascular Disease, Epidemiology, and Prevention. He's also the current president of the American Society of Preventive Cardiology and the chair-elect of the AHA Council of Lipidology, Lipoprotein Metabolism, and Thrombosis. Dr. Amit Kara is a clinical chief of cardiology at UT Southwestern, the director of the Preventive Cardiology program there, the Dallas Hart Ball Chair in Hypertension and Heart Disease, and a past president of the ASPC. And Dr. Martha Gulati is the director of Preventive Cardiology at Cedars-Sinai, the associate director of Preventive and Rehabilitative Cardiac Center at Cedars-Sinai, the Associate Director of the Barbara Streisand Women's Heart Center, and the Anita Dan Friedman Chair in Women's Cardiovascular Medicine and Research, and also a past president of the ASPC, in case you can sensing a theme here. So I thought I'd start all of you off with a nice little icebreaker question here. When you think of preventive cardiology, what are the first three words or phrases that really come to your mind? And Dr. Shapiro, we'll start off with you.
Yeah, that's a great way to start, Kirthana. I think when I think of prevention, I really think of impact, individuals, and essential. So in terms of impact, preventive cardiology really has the power to change lives, often before a patient, has an event, before they even know they're at risk. So it's really very gratifying to help someone avoid a first heart attack, stroke, heart failure, and intervene early and meaningfully. At an individual level, prevention is just not a formula, and it really requires listening to the patients, understanding their unique biology, their circumstances, their lifestyle, and trying to tailor a plan that fits them well. And then finally, essential, which I think is going to be a theme throughout our conversation today, is because prevention really should no longer be viewed as optional or secondary. It really is foundational to good cardiovascular care. And without it, we're always really playing catch-up, treating the consequences of disease instead of addressing it at its root cause.
Yeah, thank you. Dr. Kara, what about you?
Well, first, I want to just preamble to say thank you all for inviting me. This is really outstanding and wonderful to do with some close friends and colleagues. I would use the three words impact, life course, and lifestyle. Just like Michael, impact. We forget, the impact is on individuals, it's on families, it's on populations. It is incredibly important. I know we'll talk about that, and you've got a very passionate group here. Life course, I think the world maybe erred, decades ago, was waiting till people were older, middle age or older, till we start thinking about this. But, it really starts from birth and early on and throughout the life course that we think about prevention. And then, lifestyle is foundational. We have lots of great treatments. I know all of my colleagues here, we do this every day in our practices, but it starts with lifestyle in terms of the foundations of prevention.
Dr. Gulati?
Okay, so I thought we were only allowed 3 words, but it seems we were able to more than that. So, what I think about it is 4 words: saving hearts, saving lives. And I think every day when I go to work and when I see patients, what I'm trying to do is, keep them healthy as much as possible, depending on where I meet them, to make their life better and to make their hearts healthier.
Yeah, I love that. I think at the core of it, we kind of all are talking about what we can do for the patient now to help them later on. That kind of leads us to, all of you have such a pivotal role within the field itself. And I'm always curious, when you were fellows and when you were in kind of my seat, what really drew you to this specialty, and how do you think your journey has evolved over the years to bring you where you really are today? And I'll start with my fellow Texan, Dr. Kara.
Well, there's lots of prevention needed in Texas, and it's a good question, and all of us started sort of different places and in different phases in life, but it was really during residency where I just kept seeing patients over and over again. I knew I wanted to be a cardiologist, and I just kept seeing us doing PCI over and over again. There's nothing wrong with PCI, but it just didn't feel right that was our only strategy, and no one had really anything else to say. It just didn't feel like the right side of medicine or the right way we should be doing things. And equally as much, I was fascinated by the biology of why is this happening to these people. So sort of two sides. I think we're very fortunate to be in a place where years ago we were on the fringes a little bit. I think in terms of what we were doing. And when I said I'm going to do preventive cardiology, everybody sort of looked at me crazy. But I think we're really in a different place now. I'm sure we'll get to that, where it's wonderful to see prevention front and center, and everyone believes in it. And now we just have a lot of work to do to make it actualized.
Yeah, it's interesting that you mentioned that, because I feel like now as a trainee, that's definitely seen as like a path moving forward. And people are like, oh, that makes sense that you want to be interested in that. So I can't imagine having to trailblaze that path kind of on your own. Dr. Shapiro, how about you?
Yeah, I really love this question because I was never supposed to be a preventive cardiologist. No, I was trained as as an imager. So after my fellowship, I did an imaging fellowship focused on MRI and CT, and I really fell in love with those modalities. And after that training was complete, I was recruited to my first faculty position to really start an advanced imaging program. So it's all imaging focused. And it was a great opportunity. But after looking at plaque all day, every day, particularly with CT, I inevitably started to get more interested in lipids and athero and prevention of cardiovascular disease. And I think you see this a lot amongst imagers, particularly those who are focused on cardiac CT. So, as my interests were evolving, it just so happened that a very important mentor in my professional life, kind of entered the scene. Uh, he was recruited to the institution I was at to start a center for prevention, and we sort of hit it off right off the bat. And I was, really then exposed to what I would call industrial strength prevention at all levels, from basic science to translational to epi clinical trials. And that really accelerated, my transformation from being, an imager to a card-carrying preventive cardiologist. And so my clinical and research work has really transitioned over that time from imaging to prevention. And where I am now, the opportunity was to build a preventive cardiology program from the ground up, and it's been a fantastic ride, and I get to spend 100% of my time in prevention-related work.
Yeah, I think it's also reassuring to know that we're allowed to change our mind and this journey is constantly flowing,
Great
especially,
point.
coming from training where you're kind of like, okay, I just want to get into training and I just want to get through training. And so that idea that your journey can transform is definitely encouraging to all of us fellows still kind of going through the daily steps. Dr. Gulati, are you able to share a little bit about your journey?
Yeah, sure. Well, when I was doing fellowship, I realized I wanted to be a preventive cardiologist, but there was no such thing as preventive cardiology at that time, just as Dr. Kara said. So I think that for me, a lot of people, when they were, as a fellow, they're always asking you, so what's your plan? And when I'd say, I'm going to I want to do prevention, they're like, and what does that mean? And so I think that's, I spent most of my last year of fellowship of everybody thinking both this girl has no direction and we also are slightly worried about her. And so it was one of those things where you had to sort of define it yourself and create what you needed at that point. And I will say that it took a while as an early faculty member of both me defining my pathway, coming from a place that didn't have anyone really focused on prevention, and not having sort of a track to follow from someone else. And I would say I spent the early part of my career just kind of defining what it meant. I walked in my first job saying, yeah, I guess I'm running cardiac rehab if I'm doing prevention. Like I've sort of made that up. It's not that anyone I was even in charge of it, but I decided I was. And then nobody really cared. They're like, yeah, sure, you want to take care of that? Okay. Um, So I think that's like, it was unique in the sense that we all got to define the way we think of prevention. And I think we're still trying to refine and define what is being a preventive cardiologist because I think it's growing. And I think the nice thing for people that are getting out of training is that there's at least many different examples. We all do it probably a little bit differently, but there's many examples out there of the ways that you can define preventive cardiology. And of course, the American Society for Preventive Cardiology is also trying to help trainees as well see all aspects so that when they go out, because I think that's still something lacking in training, like in the COCATs, which guides, how many caths you need to do, how many echoes you need to read. There's really nothing in there for preventive cardiology. Like there's nothing saying what you need to do to acquire the skills of cardiovascular disease prevention. Hopefully that'll change, but for now, I think a lot of people at different institutions may have nothing as well to base their passion on. And so hopefully we can help them.
Yeah, that's a great point. I was just thinking about like we have procedure logs for a lot of things, but we don't really know how to define how much training we're getting. And it still varies depending on your institution. And if there is someone whose career focus is that within your own institution. You kind of mentioned ASPC, and both of you are past presidents, you and Dr. Guerra, and Dr. Shapiro is currently in his term. And so I'd love to know during your time within your leadership roles, as you were kind of growing the field itself, what would you say were really passion projects or call to action items you focused on? And we can start with you, Dr. Gulati, as the most recent past president.
Okay. Well, I think one of the biggest things that I was focused on was truly making both prevention known to the greater cardiology community and what it meant and what we stood for, but also I think also sharing what ASPC is to other societies. Like we spend a lot of time kind of partnering with different groups and establishing relationships both nationally and internationally. And I think that's how we grow up. I think we're a small but mighty organization, but we've come a long way. I mean, I don't even remember how many years I've been part of ASPC, but it's interesting thinking about the journey that I witnessed myself, but knowing where it came from when it was a small group of NIH researchers that met and weren't actually trying to get members. Like they were really just trying to meet amongst themselves. And now we're this, huge organization that grew significantly during the pandemic and onward. And every day I feel like there's people that are like either telling me they just joined or they're going to join or that they want to be part of ASPC. I just met someone here. I'm at the European Association of Preventive Cardiology, and I met a few people from the US that are like, oh yeah, I'm joining. I'm not even sure if I joined, but I want to join. So I think we've come a far way.
Yeah, absolutely. And not to mention, it is free for trainees to join, which is wonderful.
Yes,
Good plug.
absolutely.
Yeah, right. um, Dr. Shapiro, since you're currently in your presidency, I would love to know kind of what your thoughts are about what your hope is during this time.
Yeah, I mean, I think a major focus of mine and probably, in fact, all of us is really, as Dr. Gulati has alluded before, is trying to really define what the field of preventive cardiology is, articulating its scope, the competencies, its value. I think too often prevention is viewed as an afterthought or kind of folded into general cardiology without a clear structure. But over the last several years, we've worked to clarify what preventive cardiology is, why it matters, how we can create standards around training, certification, and practice, from developing curricula to guiding potentially future certification efforts. That said, I mean, I think there's still a great deal of work to be done. I think preventive cardiology largely remains in a nascent stage, but there's no doubt that there's growing recognition both within and outside of cardiology, and that prevention is not simple, and that the science and delivery of prevention has become increasingly complex. And I think this complexity underscores the need for preventive cardiology to be recognized as a distinct subspecialty. And there is also, importantly, a growing appreciation for just how powerful prevention can be in improving outcomes and transforming lives. And then the other sort of passion that I have, and perhaps closest to my heart, has really been a deep commitment to supporting the next generation. And I know all of us believe strongly in mentoring and encouraging students, residents, and fellows to see prevention not just as an interest, but actually as a viable and fulfilling career path. And the reality is that most training programs don't have dedicated preventive cardiology programs or curricula, as Dr. Galati just mentioned. So many trainees are simply unaware of the field, and you can't become passionate about something if you've never been exposed to it. So both in my day-to-day clinical and academic work and through my role at ASPC, I'm really trying to build more opportunities for trainees to engage with prevention early through education, research, mentorship, leadership development, and the interest, I believe, will certainly follow.
Yeah, I know that even within the subgroups, when we're able to join on ASPC, there's so many members from so many different institutions, and a lot of which maybe don't have a dedicated preventive cardiology curriculum, but they can take what they're learning back to their institution, which is pretty exciting. Dr. Kara, would you be able to share about your time as past president of ASPC?
Sure, and first I want to acknowledge, we each were a different time frame, and I love
Mm-hmm.
hearing what my colleagues contributed because I've seen it. Obviously, Dr. Galati has really enhanced the international exposure of ASPC and grown our member base and really made that a focus. And Dr. Shapiro, even before his time as president, was really codifying what prevention is and how we should train and what the field is, and continues to do so. My time was interesting. It was 2018 to 2020, so do the math as to where we were in life at that time. The organization was quite small, as Dr. Galati mentioned, was really an offshoot of the AHA-EPI Council, and it was in the dozens of members. And prior to me, so I don't take credit for this, there was a prior president that really helped us accelerate. We were, in the several hundreds, and with Michael, one goal was growth, and we got to over 1,000. Now we're well over that now. So that was one. With growth, though, was structure. It's sort of like a child when you're going through adolescence. And so one big thing that I was interested in was structure. So structured meetings, working groups, committees. So really trying to give structure, looking at the longevity of the organization so that we could continue to thrive. A couple of things that were important in that growth was thinking about all these new members that were now not, as Dr. Galati said, NIH sort of very specific preventionists, but really the general people, boots on the ground, practitioners out in the community, and giving them a voice. And we started something called Doc Matters, an online community, which other organizations do, where we shared cases and discussion. And anybody, it's democratic, right? Anybody can be part of that discussion, from people that were at the top echelons of whatever they were in their field to those, again, just boots on the ground in the field. And I thought that was pretty cool. Around, around 2020, there was George Floyd and COVID, and so we had to think of, as an organization, about what were our statements around that, what we were doing. We were, I think, the second meeting to pivot to virtual. So, there are always storms in your presidency, and I think the last thing I'll mention, which was probably the most enduring and the thing that I'm most proud of, was our journal. Around that time, there was a lot of discussion about, do we need a prevention journal, and other organizations had not chosen to go that route. And I'll tell you, there were a lot of naysayers and that said, we don't need this is not necessary. And I think many of, and I take not the credit, but as president, working with others in the group that said, no, we should do this. And we created a system to do that. And now AJPC is absolutely thriving. And to me, what that says is prevention is awesome, and that there's so much science out there that's
Yeah.
burgeoning, and our submissions are just overflowing at this point. So really exciting for that development.
Yeah, and we're going to get into this, but it's so important to combat kind of growing misinformation by actually talking about the science behind it as well. And so I know I'm very excited to attend my first ASPC this coming August. So um, on that note, as someone who's in their early career phases, or maybe still in training, or wants to get into that research space, what advice do you give to these trainees to really kind of encourage them that they want to make an impact within the field? Um, we can start with Dr. Shapiro.
Yeah, I think a few things come to mind. It's really about sort of engaging deeply, being curious, and really seeking out a professional home. So on the engagement side, I mean, as we've discussed already, prevention is not always the most visible or well-funded path, but I think it's
Hmm.
where you really make the most profound and lasting difference in patients' lives. So if it speaks to you, give it your full attention and energy. And there's certainly more opportunities now for people to enter a career in preventive cardiology than I think there were in the past. Then, staying curious, as Dr. Kira just mentioned, I mean, the science of prevention is rapidly evolving. It's exploding. Whether it's omics, imaging, inflammation, digital health, there's just an enormous amount to explore. So bring your questions, follow the data, don't be afraid to challenge conventional thinking. And then finally, seeking your professional home, mentors, collaborators, communities like the ASPC. I mean, preventive cardiology is still growing as a formal discipline, as we've discussed, but the people who are drawn to it tend to be mission-driven, generous, and supportive. And I would give the advice that you should surround yourself with those who will champion your growth and development and help you shape your path. So it's not just a career choice; it's a mindset, it's a calling, and we really need passionate, smart, and committed individuals to lead us forward.
Yeah, I love that. I love the idea that it's a calling. I think a lot of us are really passionate about the field. And so, any advice we kind of like to soak in from the people that trailblazed it for sure. Dr. Kara?
Yeah, listen, I think, in terms of the next generation, I was a program director and associate program director for about 15 years. And I think what happens, I totally get it, that we sometimes get very drawn, particularly in recent times, about RVUs and productivity and start to really fixate and let the tail wag the dog, where a career is a long time. And what is fashionable today may not be 20 years from now in terms of even procedural different things we're doing. So to me, it's really following what it is that drives you. Don't let the tail wag the dog about the mechanics of your career versus what if you work for 30 years, you want to get up every day and feel like, the old adage of you're not going to work, right? It's not work. And I feel that way because I do what I love every day. So I really encourage people that are leaning towards prevention, feel like this calls to me. Don't worry about the mechanics. You have 3 people on the call today, and numerous others that can tell you how to do this for a career, and that's part of what ASPC is doing with our early career folks, and tell you how this can be a viable career. But don't let the tail wag the dog, because your passion will drive you. And listen, there's so much. We have not cured heart disease, so there's so much we need to do, both research and clinically, where there's room for everyone. So I would say just follow that passion, and we can help you find a way to make that a career.
Yeah, I love that. Dr. Gulati?
I think just to follow up on something that Amit said, do you want to be in a field where there's so many people and where you don't have the opportunity to potentially be a pioneer and to sort of bring some solutions, whether that's clinically, whether that's research wise? There's so many opportunities because this field's just starting in reality. I mean, we're at, I think it's infancy. And I think that that's a great time to get in on the ground level and make it what we want it to be. And it's so interesting watching clinical trials being run by non-preventive cardiologists. It's kind of my pet peeve, but I'm like, but at point, I'm like, well, we're so cool. I guess you want to be there. The intersectionality as well in prevention is actually, I think people are realizing more than what people used to think. I think when people thought about prevention before, they were thinking, okay, like those are the people that lower cholesterol. And when I started, there was only really one cholesterol lowering agent that had evidence behind it. We did a lot more than that. And we're showing that now because there is, anyone who's read the heart failure guidelines as an example, almost half the guidelines was actually about prevention of heart failure.
Yeah,
And
absolutely.
so I think that there's so many things that have been created in the last few years, like cardio obstetrics, cardio oncology. You can keep labeling all these cardio hyphenated areas, but I really think those were founded on the basis of prevention. So there's so much for people to do, and I think that, the questions that still need to be answered are so important. I also think that, like Michael said, at one point, when we create the standards, which is what he's trying to do, is create what is the requirements to be a preventive cardiologist. And then once we're able to fully define it as a subspecialty of cardiology, I think that that is also, will lead to maybe some solutions of the challenges of how we even get paid. And I think there's a lot of people that sometimes are driven, even when they're thinking of what they want to do clinically, they're driven by, sometimes financial. And I don't blame them. I know a lot of people come out with a lot of debt. But I think that if we put the value on true health care rather than sick care, if we can make it to that place in this world, it should also be tied more adequately to reimbursement. And hopefully, I aspire that preventive cardiology should be the best paid field of all specialties because the work we do is so important. And so again, this is a funny time in life, but we do have the opportunity to really start changing the conversation. And as our society gets bigger and as the workforce of preventive cardiology becomes more influential, we'll be able to change things for the better.
Yeah, I remember, listening to this made me think when I was on my interview trail at one of my interviews, they asked kind of where I'm interested within the field. And when I mentioned preventive, they were like, oh, that's the trendy answer. And I didn't really know what to say back because I was like, well, it may be a trend, but it's not going anywhere. And so I think it was just
You're so
interesting to
cool.
hear that. Exactly. Or, they would kind of be like, oh, but everyone does prevention. And I'm like, do they though? And so I think that conversation, even in my time in fellowship, has started to shift, amongst everyone that's like, I want to do this or I want this procedure, I want this. I was like, well, I'm interested in prevention. And it's now shifted to, oh, our institution doesn't have someone that's interested in that. Like, do you want to stay on and work afterwards? So it's kind of cool to see, even within my couple years of training, how that shift has happened.
You raise an
Um,
extremely important point, which is, I think, what all of us are trying to say is that we really need to create the definition of prevention because I think it commonly gets conflated with general cardiology. I mean, never have we been accused of being trendy as preventive cardiologists. So I think that there's just some common misconceptions about what prevention is, and now, fortunately, with diagnostic approaches and therapeutics exploding in prevention, it's getting pretty complicated. And I think that many in general cardiology who just would not be as interested or don't have the bandwidth to take on all of these other things. So we do need to get beyond that hurdle. And Dr. Galati was just mentioning this, in terms of understanding exactly what preventive cardiology is, which is not easy to do because it's constantly evolving. So
I would love to
thanks for
pick up
bringing
on
up
that
that
point,
point.
Michael, because I think this comes up a lot. Remember when I started about 20 years ago and I was having lunch with a potential referring internist and they said, well, I can prescribe a statin. So what do you do? What is it you do? And, I analogize this that I can take care of AFib. I'm a general cardiologist, but my electrophysiologists do a lot better than I for complex cases. And I think you have to appreciate it is, with all the different therapeutics, genetics, imaging, integrating it, frankly being facile lifestyle, we have a whole long list for our fellows in terms of the competencies around training. It's not for the faint of heart. It is a true specialty, and I think that analogy for me is to I think getting past what exactly are you to people appreciating how complex it is and seeing people refer to us because they're saying I don't know what to do with this. Let's talk to
mhm.
preventionists. So it's great to see this evolving, but still some work to do to help people understand what it is prevention does.
Exactly, because I think sometimes people, even where I am, sometimes they'll be like, oh, well, you're general cardiology, so we'll send these patients. And I pre-screen all patients before they can actually be put on my list. And I don't take general cardiology patients, actually. I sort through the ones and I'm like, yeah, this is appropriate. This one, no, that one goes to general cardiology. And we have general cardiologists who enjoy being general cardiologists, but they don't have the expertise I have, and I don't necessarily have the expertise that they have. And I think, again, the more we define it, the better it will be because what you experienced, I hear quite often, but it's something I think that makes us passionate to also define what we do.
Absolutely. Even within the field of cardiology itself, I think there's a lot of confusion. And so I think moving in that direction will help people to maybe not call it trendy and be like, oh, that makes sense. I would love to just walk into a room and be like, that's what I'm interested in. They're like, oh, that makes sense. That's I think where we are headed. I'm going to pivot a little bit here and kind of talk about how you approach, prevention in your clinical practices. And so one of the things that I think I've noticed is despite all the strong evidence and data supporting preventive strategies, implementation really remains inconsistent. And especially in a place that doesn't have someone dedicated to prevention, what do you see as the biggest barriers to really integrating prevention into routine clinical practices for someone, say, who doesn't have the ability to refer their patients out to someone within that field, or they're not in an area that's amenable to that? We'll start with Dr. Kara.
Yeah, thanks for the question. I mean, there's so many levels to prevention, and if I were to start with just sort of broad, you know, general risk factor, addressing risk factors and screening, I think a big part of that, frankly, is the way our health system works. That we're fee for service, and so where these things are not compensated, it just sets up our care models that are more on the doing, the treatment side on the back end of disease rather than on the prevention side. We're just not, and if the health systems flipped to where models were different around care, it would change immediately. And so that's one big barrier. The other is, which everyone knows. I am going to bring up social determinants of health because there's a lot that we want to do, but without addressing those, many of the therapies we use are quite expensive, even coming to lifestyle, not feasible for many patients, depending on where they live and what their social situation is. And I think the last thing I'll say is, as you mentioned, even in places where there's, prevention's practiced in different ways. In our practice, I'll speak for my practice, it ends up being complex patients with, sort of very challenging situations. It's a little bit different than population level prevention. You kind of need a little bit of both, and preventive cardiologists can be the champions for both, but those systems are a little bit different.
Yeah, absolutely. Dr. Gulati?
Well, I'd agree with everything that's already been said. I think also sometimes the way that we think about prevention, just using, for example, how we do risk assessment. We're thinking about a population, but we have the individual in front of us. And whether that, whether these formulas that we make up work for the individual in front of us, and whether that is useful or not. These are things that are challenging, but they kind of become barriers for implementation on whether we're asking primary care or GPs to do those kind of things to screen for patients. I think sometimes these formulas that we come up with aren't always adequate for the one-on-one. And I think that we have to think always about how can we make things as simple as possible to help both our patients, but also help the people that are implementing things.
Mm-hmm.
I also think that the value in a system, though, when you don't have preventive cardiology there, I think I do see it in certain places being at least assessed. And maybe that will bring the value of a preventive cardiologist as an idea for a system is related to when we do quality metrics, right? So there's money on the table for hospitals related to heart failure readmissions. And so many hospitals across the country have looked at, how adequately they've been treating patients after. What's the follow-up been? Did they get to cardiac rehab? There can be metrics after PCI, metrics after acute myocardial infarction. At least that's a way of them measuring how effective they are at their secondary preventive efforts, which for most hospitals isn't great, right? So that's where a preventive cardiologist value certainly is, but also thinking about creating avenues and access for patients where maybe specialists don't necessarily, like other specialists don't see that as their job, or they're overwhelmed, or they're dealing with such sick patients, that there's a way for us to share in some of the care, reducing rehospitalization, maybe even leading in the quality metric side of their hospital setting can be a way that we can be of value as preventive cardiologists.
Yeah, absolutely. And the individualized approach is probably at the core of it, what adds to the complexity. Each patient has a lot of different contributing factors within their presentation. Dr. Shapiro?
Yeah, I mean, obviously there's several barriers to integrating prevention, and I agree with everything that's been said. And I would sort of just double click on something that Ahmed had mentioned, which is that I think the biggest barrier is just the way our entire healthcare system is oriented structurally around the treatment of disease, of course, and not prevention. And as he said, we reward procedures, reimburse acute care, but kind of marginalize the time and complexity for prevention of events that have yet to occur. I think that also prevention culturally kind of demands a different kind of clinical mindset. Individuals who really value long-term thinking, risk communication, patient engagement, and that takes a lot of time and consistency and continuity. All things that are often in short supply in many practice settings. So I think that's a barrier. And then one that I've kind of stressed already, which is the barriers in training, right? So most of us have not had meaningful exposure to prevention as a discipline and simply not aware of the tools, the strategies, maybe even the guidelines that exist. And I think if clinicians don't feel confident in delivering preventive care, it's going to get deprioritized. That's what I see.
Yeah, it's interesting because in today's age of digital media and our ability to disseminate information, people find resources in a lot of different ways, and the general population, even some clinicians, don't really know how to combat all of the misinformation that's it's coming out. And so, what would you say is the approach that we should take to combat that growing misinformation? If a patient comes to you and they said they've read something or they've seen something or someone has told them, and I know this is definitely probably could have been the whole podcast episode is how to combat misinformation. And that's something that I've noticed kind of an active effort with a lot of professional societies, but especially with prevention. And because kind of that catch-all word that people can take in whatever direction they really want it to. And so if someone brings something into you in clinic, how do you really combat that? And we'll start with Dr. Gulati.
Well, I think it starts before clinic, to be honest with you. I think this is why I am on social media, and this is why, in fact, I started on Twitter when there was probably 3 or 4 other cardiologists on Twitter. And I wasn't really tweeting or interacting for cardiologists' sake. I was actually trying to reach patients, really
Mm.
to be a voice you know, of someone that at least is in the space that could give people valid evidence-based direction and share science with them. And so that's how I started, but I do think that one of the things we need, especially from our younger generation of cardiologists coming up, particularly those in preventive cardiology, is to be the voice out there. Use the different social media channels that you use to really correct the misinformation and be the voice out there. I, you know, I on many different channels. One, I use Instagram to show to my patients and I guess some cardiologists that I exercise every day. But I do have a lot of patients that find me on there and have told me like that's motivated them. They realize I literally walk the walk. And it makes them do things. But I also, anytime there's like somebody saying, this is the best medication known to man, or you don't need to be on statins because hormone replacement therapy is actually the cure for all women. I'm out there, and I've joined forces with other big voices, like recently with Jen Gutner, who's a obstetrician and gynecologist, and she has a big platform. So together we talked about that whole thing, why are people saying these things that are completely wrong, and how to, just to be able to, again, get the messages out there. So I think the younger generation that's on different platforms, hopefully they can take it. There's a role for everyone to be out there correcting misinformation in a kind, professional way, because by being a physician, I think you have more credibility than anyone else. And agreed, there's some people who are physicians who are not credible out there, but I think there's also non-physicians out there making millions off of supplements, and we really need to be combating it. In the clinical situation, you're absolutely right. I work in California. Their supplement list is always longer than their medication list. And so I'm always telling them the same thing. I sort of have my elevator speech, like why, how supplements are not followed in this country, how just the safety of them can't be assured. Same thing with compounded medications. And why, we have this discussion usually about why they dislike or why they're worried about prescription medication. And I try to be, open-minded and allow the patient to express why, what their concerns are. But I bring it up at every visit. Like, we continue to talk about it. And it's amazing once you have a good relationship with your patients, you can start breaking it down. They're more willing to trust you. It's not on visit one, and we should never write off a patient who has beliefs or is going to says I'm never going to take something. Be patient, because the more they trust you, you'll be amazed. And those are the victories I celebrate every day. And I love when a patient tells me, I kept listening to you, you just never stopped saying it. I think that that's the way that we can actually help individually with our patients.
Thank you for sharing that. And in the interest of everyone's time, I do just kind of want to end with, for clinicians that are interested in listening to this podcast, learning more, and kind of want to get involved, what is one takeaway message, kind of bringing back to those, now you get one instead of three words, one takeaway message that you'd really want people that are listening to tune into this podcast to get out of this? Dr. Shapiro, we'll start with you.
Yeah, I think this is going to be a great way to wrap things up. What I would hope is that we can convey a message that, prevention is not a soft science. It's not an optional add-on. It's really the most powerful tool that we have to reduce the burden of cardiovascular disease. I think we all feel this, that the opportunity to prevent a first heart attack, a stroke, heart failure, it's really profound. And yet we often treat prevention as a secondary, as something to do if there's time or only after the disease has already arrived. And that mindset really needs to change. So for me, preventive cardiology is not just a professional interest. It's become really a deeply personal commitment. And I've seen time and again the difference it makes when we catch risk early, when we listen to patients, intervene before the damage. And also, unfortunately, we've all seen the heartbreak when those opportunities are missed. So we absolutely need to get serious about prevention. If we're going to meaningfully address the number one cause of death and disability around the world, there's really no alternative. So it has to be treated with the same urgency, investment, and rigor as other subspecialties in cardiology. And I think the future of cardiovascular care and population health really depends on it. So it's not always simple, it's not always easy, but it's essential. And when done well, I think it's the most rewarding work in medicine.
Yeah, thank you. Dr. Kara?
Well, this would be a little self-serving, but I'm gonna say join the ASPC. And the reason is, in truth, my story, quite a while ago, I Googled when I was starting in prevention. I didn't know, and I saw this thing called ASPC, and it was again I went to this dinner. It was a very small group, and because everyone's looking for a home, and I think this is such an incredible home for people. There's something about numbers and not having to, being in a like-minded group. I think as you'll go to your first ASPC meeting this summer, you'll feel it, where you just feel like everyone's there, shares your temperament and your enthusiasm for prevention. You're learning a lot, and you're really just accelerating rather than trying to help understand what prevention is. And so I really think for people to expand their careers and advance in prevention, join the ASPC.
I love that. Dr. Gulati?
Okay, so nobody really is answering with one word here. I, I just want to go on record that both these guys don't know the one word answers. So then I guess I can't answer in one word, but I will just say I agree with everything that's said. I think the prevention community is a unique community of amazing people. If you are trying to figure out where you fit in, it's like very likely you'll find this community to be welcoming with open arms. I think it's one of the most exciting areas that you can be involved in. And when I was training, it was definitely everybody said they wanted to be an interventional cardiologist. And so I always say, and people know this, that my term for prevention is early intervention. So you can be an early interventionalist, still sound really cool, and spend more time saving lives than in any other field within cardiology. And I think that's what makes me excited every day also to go to work and know what I'm doing is going to change people's lives.
Well, I'm just so grateful that the three of y'all took time out of your busy schedules from all across different time zones and countries to join us this morning for our first episode. And I can't wait to see kind of how this develops and meet some of y'all for the first time in the conference in Boston. Thank you guys for taking the time to do this today.
Thank you.
Thank you so
Thanks.
much.
Thank you.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.